who needs a spine surgeon. And again, it may seem kind of simplistic when you decide to send someone or refer someone. Other times it's you're not sure, and so I just want to clarify some of the key things. In general, let me first state that we're always happy to accept referrals for this, and the nice thing is at a major tertiary center like this, and with multiple satellites, whether the patient is referred to one of our PM&R specialists or a spine surgeon, either way, they get evaluated and they get worked up and get sent to the right person one way or the other. But we'd certainly like to educate you all as our participants in the webinar to really kind of clarify the different scenarios and clinical presentations that might be better served for a spine surgeon versus otherwise. The other thing, as I start my talk, I want to give a very special thanks to Dr. Raymond Ha, who really is the one who developed this talk. I'm using essentially all of his slides and just added in my own commentary on a lot of it, but really superb job by Ray on this. So my disclosures, really none relevant. I really do not do any consulting anymore for the different companies, although I use a lot of different products in my practice. So first off, when we're discussing the evaluation of a patient and what we need to address, first and foremost, there are some emergent conditions that you really just can't miss. So whether you're in family practice, you may be a nurse practitioner, a physician's assistant, an occupational therapist, physical therapist, or even another spine surgeon, there's certain conditions that we just do not want to miss, that we declare are emergent and certainly urgent conditions that need to be addressed promptly. There's other scenarios that are optimal elective surgery candidates that may or may not be relegated to non-surgical treatments first, but certainly there are some scenarios that are ideal surgical candidates and warrant referral to a spine surgeon, and then I'll give some final thoughts on the issues. This is an obvious case. Both of these, one is obviously a cervical CT scan, and the spine is out of alignment on the lateral view. It's a fracture dislocation, and then the other is the CT cuts of a fracture dislocation of a sacral fracture causing severe sacral nerve root impingement. Both of these are obvious on the imaging and probably going to be obvious even in the clinical presentation, but it's not always. The not so obvious these are examples. It may be someone who presents to the office, they were involved in a motor vehicle collision either last week or last month, and they have persistent pain, which may be presented as not really that bad of an accident. Other people may have been in a rather horrendous accident, but it happened weeks ago in a more distant past, but they still have persistent pain and never had a full workup, or maybe not even any workup at the time. So these are the conundrums we get into when you're deciding, what kind of workup and what to do, and who should see a spine surgeon or just do initial imaging in your own office. What is warranted? So most of you all in the audience are in your own community practice, ambulatory setting, where you're not working in the level 1 emergency trauma center. So generally speaking, you're not doing a full trauma workup on probably any of your patients, but there are patients who warrant a more aggressive workup. And depending on your own practice environment, if they do present with these more impressive traumatic mechanisms, may warrant immediate referral to a local emergency room, or if you have the capacity to at least get some basic imaging in your own office. So I think if someone comes in with somewhat distant trauma and complains of persistent pain, at a minimum, it warrants a full clinical evaluation and imaging studies of that area in your own office if you can do it on the same day. If depending on the clinical scenario, and we'll touch on this in a little bit, if it doesn't seem like it's as high of a traumatic mechanism, it's more of a persistent pain with no overt neurologic deficiencies, then a referral for advanced imaging, whether a CT scan or MRI. I'll just touch on this briefly. In today's day and age, most of the time, we have enough MRI imaging centers and capacity to get that. So MRI is generally in the community practice going to show you the most number of things and rule in or rule out the different conditions that we absolutely need to see, and rule in or rule out. So in general, most of the time, I would always advocate to have someone get an MRI as the initial advanced imaging. Some people are claustrophobic, have a pacemaker that or some type of implant that contradicts getting an MRI, and that's where a CT would certainly come in to play. But most people, if warranted, I'd get an MRI as this advanced imaging. So anytime someone comes in with a traumatic mechanism, whether it be a small slip down the stairs, maybe someone just trips and falls in the parking lot, they have a motor vehicle accident. A lot of people don't seek immediate medical treatment unless it's of more of a catastrophic nature. They want to come in and see their local doctor or nurse practitioner, or get referred to a therapist or chiropractor, and there's no imaging. So certainly if someone has persistent pain and there's a traumatic mechanism, at a minimum, I would recommend, as we said, do a complete history and physical and get basic radiographs of the painful region. If there's a real high level of concern where the pain level is such to an extent, or the mechanism is extremely traumatic, there's no fault in giving them immobilization of a C-collar and sending them directly to the emergency room or an urgent care center right away. No one is going to fault you for this. And so you need to have your clinical suspicion up for these scenarios. The other scenarios that warrant referral and urgent referral are cases in patients where there's infection or tumor or some type of finding, and these are the least obvious. The number one presenting symptom for someone who's got some type of spinal cancer or spinal infection is actually just plain old back pain or neck pain. It's not that they have a whole multitude of other unique symptoms. But the thing that often stands out, and we call these the red flag symptoms, are when there's kind of pain out of proportion to their presentation or their traumatic mechanism, or some other constitutional symptoms, whether it's fever, chills, night sweats, weight loss, some of these other symptoms that seem to correlate with the onset of their ongoing persistent pain. So how do we distinguish between the bad, dangerous back pain from a benign low back pain condition? Well, it's often challenging because there's such a high incidence of regular back pain in the population, and the vast majority of these people recover with essentially minimal or no treatment, most of it undertaken on their own. However, a lot of these ultimate treatments are a significant cost to our society, since it's the second most common cause of missed work. It's the second most common reason people seek medical attention, and it certainly accounts for a very high percentage of inpatient hospitalizations and surgical treatments. Touching on what Gene talked about in his first slide, I was really chuckling about that. Most people do come in with self-diagnosis and may have diagnosed themselves correctly and many incorrectly. And some have even tried some of the various treatments or devices that are available, especially now that we've been holed up in our homes and people have to fend for themselves to shop for their own treatments. So there's a lot of big variety of treatments that people seek out, which I don't fault people. People do want to get better, and it's not always that convenient to see a doctor. Why do people have such a high incidence of pain? Well, look at how we live. We're hunched over computers. We're commuting, long commutes, especially here in Los Angeles area, and it's just a setup for problems. And then, not to mention, the aging process takes a toll on your body, and the spine is the main weight-bearing component in your body, and endures such a load on a daily basis, even when you're sitting. So what are the basic treatments? Well, I'm definitely the biggest advocate for non-operative and ultra-conservative care, meaning exercise, back simple treatments of core stabilization. Most of the people, when you get down to it, can be treated with home exercises, especially after having a few sessions with a therapist or even a chiropractor. The problem is most of these treatments don't work as a one-off treatment. It's like brushing your teeth and treating cavities. You can't just brush your teeth for 5 hours straight. It really takes some amount of daily exercise and conditioning to be the best treatment and or preventive measure for ongoing back problems. The other is just simple ergonomics of their daily activities. And this is where the physical therapists and occupational therapists really, I think, do their best work by training patients and teaching patients how all their daily activities really factor into ongoing problems. In addition, just a healthful lifestyle can really factor in as well. So getting back to what are the red flag symptoms? Again, night pain, pain at rest, someone who has pain that just doesn't get better with anything. Usually most of the strains and sprains and even the traumatic conditions have some mechanical component where they're worse when they're twisting or bending or doing something. I worry most when people tell me their pain is actually worse just resting at nighttime when they're sitting still, or when they have fever, chills, night sweats, weight loss, other kind of unusual symptoms. That really favors a more urgent workup, or some type of neurologic deterioration or neurologic deficit where they've got a focal weakness. They say their whole arm or leg is going numb, and they have maybe abnormal walking or gait, or certainly bowel or bladder incontinence that corresponds and correlates to their worsened back problem or neck problem. So again, a lot of times it's putting all of these symptoms and complaints together to warrant that concern. Here's a MRI of someone with metastatic prostate cancer. It was diagnosed because not only did they complain of the back pain, but it was listening to some of these other subtle complaints that were ongoing. and therefore deserve a more aggressive, thorough workup with an MRI scan. Again, this is a subtle finding of someone who's got cervical myelopathy, as you see the cord problem, where they just notice persistent numbness and abnormal gait and some subtle neurologic problems. And again, this is the treatment for that, whereby you can do a cervical laminoplasty to treat that and hopefully get them better. Here's a more acute disc herniation that didn't necessarily present acutely, but it was probably a gradual worsening of a semi-acute event that then did develop into full-on neurologic deficit in the upper and lower extremity, and was effectively treated with a relatively straightforward anterior cervical discectomy surgery. And I'm going to spend just one more minute on one of the subtle conditions that definitely deserves referral is cervical myelopathy, which is basically arthritic condition of the neck causing spinal cord compression and ultimately gradual worsening of neurologic weakness, sensory deficit, and gait abnormality. The problem is, as it gets worse and worse, a lot of times it's unable to get patients better. It's a matter of treating it effectively so they don't get any worse than they already are. And this is a MRI. You see on the sagittal view there, the spinal cord is compressed at multiple levels, causing cord inflammation. And this is the cartoon illustration of that. So again, the symptoms are often insidious and gradual. So a lot of times patients don't seek immediate care, but one of the hallmark symptoms is fine motor changes of their hands. They can't write very well or do buttons, or they have more problems walking and are not as steady walking, and may have more falls that they didn't used to have that problem. On the exam, they may have abnormal reflexes, tandem gait is abnormal, and hyperreflexia. Another subtle sign is the Hoffman sign, where you flick the finger and it has a reflexive beating, as well as ankle clonus and Babinski testing. Again, the surgical treatment is paramount for this. There really is not an ideal non-surgical treatment, as we looked at for the cases of infection. It's going to require urgent antibiotic treatment and immediate recognition of the condition. A simple questionnaire often delineates people who can have myelopathy or some underlying neurologic progressive problem, and the biggest symptom is just progressive weakness and numbness. But as you can see, almost everyone has the worsened neurologic findings. So when it comes to elective spine surgery, certainly patients who have failed non-surgical or non-operative care and have persistent problems or worsening neurologic problems with simple discogenic or degenerative conditions may often be candidates. But again, the key is the constellation of symptoms combined with correlating imaging findings that allow us to change the structure and effectively correct it. But be that as it may, I certainly do not fault people who have persistent pain, worsening function, to get a referral for the spine surgeon, and we're always happy to accept those patients. But as I said, we've touched on the patient scenario that require more urgent or emergent referral. So when it comes to diagnosing and treating the ideal and appropriate patient for surgery, it's really taking all of those into account, the symptoms correlating with the physical findings in the imaging, as well as helping the patient understand what are reasonable expectations for that condition, and therefore we can achieve the ideal and hopefully a very superb outcome. And this is just a final slide talking about patients who don't always actually do as well. It's when they have a lot of other psychosocial factors involved that are actually overshadowing their pain, subjective complaints, and sometimes even overshadowing the physical objective findings. So in conclusion, it's really our job to give people education about whether a surgery may appropriately help them. And often the patient's pain is not necessarily directed or correlating the need for surgery. It's really the combination and constellation of the pain, the neurologic and physical findings combined with the imaging studies.